front, as an electrophysiologist and I think as cardiologists, all of us first, the takeaway should not be that Micra is here to replace the default transvenous pacemakers, because regardless of all the developments and the growth this device has seen in the last 2 years, like we've been seeing with all the other areas in the last 2 days, still the default, I mean, the conventional pacemakers also have grown. Now you have physiological pacing where you can pace the conduction system. So by and large, when you have the normal circumstances, we can pace, you have venous access, there's no problem. You should still consider a physiological pacing, considering the benefits of that tool. But that said, leadless pacemakers have really come of age, and there are a lot of limitations which were there with this device earlier have now been addressed. That said, sir has already warned me about the lack of time, so I'll quickly jump to the business end of, I'll just quickly show you a short case, and then if time permits, then I'll probably walk you through some didactics, theoretical aspects. Pardon me for this. Yeah, so now considering the tools, I'm just talking about how to deliver it and do it. It's rather a very straightforward procedure, seems a bulky device, but this is overall the system and the device. It's a very small bullet-shaped device. This is the delivery catheter that you can see, and the introducer sheath. Just a second again. Yeah. So yeah. So the sheath, the outer diameter is about 27 French. The inner diameter is 23 French rather. It's a big sheath. Although it's coated with a hydrophilic coating, you can feel it when you take it in your hands. But it's a big sheath at the end. You might want to give a lot of local anesthesia in the groin because it does cause a lot of discomfort. And you might want to have the patient on a little bit of fentanyl as it passes through the IVC, because patients do get really uncomfortable at that stage. So this is the delivery catheter. I'll dwell a little on this. Now, the delivery catheter is a flexible catheter. Naturally, it needs to deliver the device at a certain point, so it's flexible. So there are few buttons that you see here. Now, the blue one is the one which, the gray one that is right in the middle here, is the one which is the first thing that you need to do. Once you are into the, I'll show you a case. So once you are into the RA, the sheath, the catheter in the RA, you got to flex it, and this button is going to help you do that. So you can see that, the icon here, it's going to flex the catheter, and then you're going to get across the tricuspid into the RV. Once you are in the right place, you deploy the tool, the Micra device, the leadless pacemaker, using this button. You got to pull it back, and that unsheaths the leadless pacemaker, and basically it has a mechanism by which it latches on to the myocardium. Once you unsheath, the tentacles come out, and then eventually we use this to release the tether, and I'll show you through a case. Yeah. So this is a case that we did about 3 months back on a gentleman who had a severe purulent infection on the left side. He was an 80-year-old gentleman. He had AV block, so he thought it was the right case. He probably considering the life, Micra is a good tool, considering now you have AV Micra. So watch this, the sheath, look how big the sheath is. So you got to have the wire all the way in the SVC, the sheath goes in, it's a hydrophilic sheath, and you should land up somewhere in the mid to lower RA, the sheath ends there. And you watch the patient always on a temporary pacemaker because he had profound AV block. Now, once you are into that mid-RA area, take the delivery cable, the delivery sheath inside, and in RAO view, somewhere around RAO 30 to 40, try to cross the tricuspid valve using the flexing knob that I showed earlier. Now, why RAO? Because now RAO opens up the RA and RV. You see them pretty much aligned, and you can see the tricuspid valve, and you can essentially cross the tricuspid valve using the right degree of flexion. Once you are into the RV, you start clocking the device. The reason why you want to clock is you want to end up in the septum. Now we have started implanting Micras in the septum because the tool allows us for that. So you want to clock, it takes you posteriorly and towards the septum. Once you feel that little resistance, you know that you have hit the septum, and then you quickly switch to LAO, this view around 30 degrees, and then push. Don't be worried because it's the septum. You give a puff of contrast, you have the septum, push, so that you get a little indentation. You see, it's a very flexible delivery cable. It flexes. So once you get enough leverage, you start unsheathing the Micra. You know that you're in the septum, you start delivering the Micra. Using the knob, you start pulling the sheath back, and the Micra, as soon as the Micra is exposed, the tentacles are there, and it latches onto the myocardium. You see that? That's what we're doing. Once you're at that septum, you're basically unsheathing, and there you go, the Micra is deployed. You're not released yet, but it's deployed. Okay, so then you've completely released the Micra, yet not fully deployed, and you release it, and there you can see the Micra movement. It's still tethered to the delivery sheath. At this point, all of this is reversible. You don't see the stability, you're not happy with the delivery, you can still reverse it. Then finally, like we do in the AST, atrial septal defect occluders, you do a little tug. So you release it, pull it back with the tethers and see whether it's latched on well. And it takes a couple of, it's quite straightforward. If it's latched on well, it looks stable, and eventually you release it. And that's where you see this is in the AP view, rather RAO view. It's in the septum. You can see clearly it's not at the apex, it's the septum. And this is in the LAO view. LAO. So now I'll walk you through the little theoretical, if I have some time. Do I have some time? I hope I do. Okay, so why Micra? Because we know the reasons why this device is. So despite all these developments of the conventional pacemaker, you still have a lot of lead-related complications. Pocket complications, infections are always a worry. So that's the reason why this device will always be in play. And it has, in fact, after the inception of this device, it has absorbed a lot of this headache, and now you're able to find a lot of patients getting the right solution for their problems. Now, why is the infection rate a lot lower with Micra? Naturally, you don't have a subcutaneous pocket where you can seed an infection. The catheter is preloaded. That's why you don't really handle the device, and that's why the chances of infection are a lot lower. Plus, you are delivering this device inside a ventricle where you have a rapid blood flow. So there is no real worry of infection seeding on the device. Apart from that, there are some other reasons why the company claim that this is less prone to infection. By and large, these are the reasons why it is. Now, problems. Earlier, we used to have, when you have Micra VR or single chamber Micra, you had this lack of AV synchrony, which was a significant limitation of leadless pacemakers. Pacing-induced cardiomyopathy, when you used to deliver leadless pacemaker in the apex, used to be a problem because that was very common that we saw. And it still, despite all the developments, this device is still not suitable for sinus node dysfunction. Do not use leadless pacemakers for sinus node dysfunction. It is a disservice to the patient. That said, with time, the lack of AV synchrony with AV Micra and with septal pacing, the cardiomyopathy concerns have settled down to a large extent. Now, this is where we used to have apical pacing. We used to have a lot of complications, perforations, late heart failure because of the apical pacing. Now, trials have shown that you're getting close to 85% AV synchrony with leadless pacemakers. It's never going to be 100% because it's not an electrical AV synchrony. It is a mechanical sensor. So the lead, essentially, the device senses the atrial mechanical waves and then marries that to the ventricular pacing. But 85 is still a good number and still work in progress. Again, cardiomyopathy, because of septal pacing, has come down remarkably. Now, most important, it's a little complex, busy slide, but don't try to read everything. Most important is your vascular issues, where you do not have, you have vascular occlusions, pre-existing leads, indwelling catheters, risk of infection, already eroded pockets, or somebody who's at the risk of pocket erosion and infection, hemodialysis patients where you have precious venous lines, or lack of, sometimes you have congenital anomalies where you do not have the venous access on the superior vena cava side. So these are all cases where you could consider Micra. Again, a situation where you have elderly, senile, demented patients. With the inception of AV Micra, you see them having one device in their lifetime. AV Micra is a good enough device. So these are a few indications where you could consider to squeeze in this device. Most important, where still not to do, despite all the developments, where would you like to avoid a Micra? When you have a sinus node dysfunction, all you need is an atrial pacing. giving a ventricular pacing device is a disservice to the patient because the patient will probably become more symptomatic. So never use Micra for sinus node dysfunction who have good AV conduction. High sinus rates, you might, somebody who's athletic or somebody who's probably, has a lot of sinus tachycardias, you would like to avoid these devices because the AV synchrony is going to be a bit of challenge. They may not be having a good AV synchrony, and that's where the conventional devices would be a lot better. Weak atrial contraction. So for example, severe diastolic dysfunction, previous valve surgeries, cardiotomies, you would like to avoid this device because the AV synchrony, because the mechanical wave from the atrial cavity is going to be a little challenging. So again, busy slide, but let me simplify it for you. Overall, avoid it in sinus node dysfunction. When you have somebody with permanent AF, with slow ventricular response, Micra, single chamber Micra is a straightforward answer. If you have AV block, then factor in these factors that I said. If you have a weak atrial contraction or previous cardiac surgery or an elderly individual, dementia, take in all these factors, look at the lifespan of the patient and then choose your device. You are justified to use a Micra there or a leadless device there, given now you have AV synchrony possible with Micras. Now, again, it's a little busy slide, don't worry reading through it. When we implant the Micra initially, the device takes a little while we put it on VDD mode, which is to track the atrial activity, but the device takes a while to sense the atrial activity and it remains in VVI for the first few hours. So don't get disconcerted that it is not having AV synchrony for a few hours or a day or so also, because it's sensing the atrial, training itself. After it has sensed the atrial waves, it trains itself, and then eventually you will see a good AV synchrony like this. So here you see AMVP. So ASVP is replaced by AMVP. So atrial mechanical sensing, which is followed by a ventricular trigger. Now the VE here is representative of end of ventricular systole. That's again some annotation that you see in these devices. So a complex slide. Essentially, Micra or the leadless pacemaker AV Micra senses the early diastole, which is A3, and late diastole, that is the atrial contraction, which is A4. And these are the two waves which it senses, and if it's sensed well, it triggers the ventricular pacing by using this. So I think we've discussed about the rest of it. Thanks a lot for the opportunity.